Hi, my name is Dr. Peter Jurcevic. I'm an obstetrician and gynaecologist, and I have 26 years of expertise. And I have special interest in both high-risk obstetrics, but also in the natural aspects of the birthing process. It's my pleasure to provide you with advice and care. I'd like to talk to you about assisted delivery. The aim for most women when they're having a vaginal birth attempt is to push their baby out themselves. But in about 15% of cases, you'll need to have some help from the obstetrician in the form of a forceps or a vacuum to assist the baby out. We're all trained in being able to do this very carefully to obviously protect the baby and also to protect your birth canal. There'll be various reasons why this might be necessary, and these would include the baby being distressed and it not being appropriate to wait any longer for you to simply keep pushing, or if the baby's in an unusual position or you've been pushing for too long and are exhausted and need to have that last little bit of help to ease the baby out. The choice of instrument between the vacuum or the forceps will be determined by the obstetrician and the signs on examination at the time. Both can be used very carefully and very safely, and you should never be worried about the outcome. In a lot of occasions, you would need to have an episiotomy cut to help to facilitate a little bit of extra space, but if you have done appropriate preparation in the lead up to the birth, using, for example, the epinopelvic trainer, you can occasionally do these deliveries without needing to have a cut fashioned. And this would be certainly something that I'd be aiming to do if I was looking after you. There are also situations where you would need to have a caesarean section or may wish to have a caesarean section. It's very important to understand that you do have a choice in your birth of your baby. For a caesarean section where it's an emergency, again, there can be a number of reasons for this, and this would be the baby being distressed and it being too early in the labour process for the cervix to dilate up anymore, or if the baby is jammed and stuck and not lower down in the birth canal to be able to be delivered with a forceps or vacuum, amongst other things. For those situations where you choose to have an elective caesarean section, whether it be for your first birth or as a repeat caesarean section after a previous caesarean section, then I would usually offer the opportunity of doing a maternally assisted Caesar. This is a fantastic way of getting a great connection with the birth process, even though it is an operative delivery. Once you've had your spinal anaesthetic and a numb from the waist down, you have a catheter placed, we clean your abdomen, and then we start the delivery with your hands scrubbed and you being gowned and gloved. As I start to bring the baby out through the incision in your abdomen, I then gently guide your hands down so that you can grab your baby and bring your baby straight up onto your chest to give you that immediate connection, which is really important. After that, we offer you delayed cord clamping, which is the same as we'd offer you at a normal delivery, and this allows the baby to establish respirations, increase its colour and tone, and get a little bit of extra iron infused. After that time, we cut the cord, we bring the drape back up, and we go about repairing the wound and completing the operation while you're enjoying the time with your baby. It's a truly great way of having a great connection with an operative birth. I would like to talk to you about the difference between Braxton Hicks and labour. When you are pregnant, your uterus, which is a big ball of muscle, is stretching with the growth of the baby. It is normal for stretching muscle to fasciculate or spasm, kind of like getting a cramp in your legs when you exercise. We give this a fancy name, Braxton Hicks. Braxton Hicks are quite common in the latter stages of pregnancy and are particularly common with successive pregnancies, and certainly women who've had one or more children will notice that their Braxton Hicks are often more frequent and stronger for their subsequent pregnancies. The difference between labour is usually obvious, as they are not quite as intense as a contraction in labour, and they also don't come on quite as frequently or as strong. For labour, we break labour up into 3 stages. First, or the early phase, second, or the accelerative phase, and then pushing, and then the third phase with the delivery. The first phase of labour can be really variable, and for most women it can be protracted over a number of hours, with the contractions coming on maybe every half an hour, then every 20 minutes apart, then every 10 minutes apart, getting to around about 5 minutes apart when we would say you're becoming more established. Those contractions will maybe begin lasting only 10 seconds at a time and will progressively increase in length up to anywhere between 30 seconds to a minute. And as you'd imagine, the intensity will increase as they become more frequent and as they become closer together. Usually when contractions are coming approximately every 5 minutes apart and lasting at least every 30 seconds, and they're really starting to take your breath away and catching you, that is usually an indication that you're getting into a more established pattern of labour. We would usually hope and expect that you'll be getting dilation of the cervix in response to this. It is usually advised that you would call the labour ward and speak to one of the midwives to update them on what's going on, to see whether or not your waters might have broken, to give them an idea of the number of weeks pregnant you are, how the pregnancy has been going, a swab result that you might have had taken during the pregnancy for the GBS bacteria and so on. This will help the midwives to guide you when it's time to come in, and they're usually very good at making that determination. Once you arrive at labour ward, it would be hoped that after you've had an initial monitor of the baby, we'd be able to examine you and see that your cervix is dilating. And in a perfect world, you'd be at least halfway there, i.e. 5 centimetres dilated or more, knowing that dilation goes from 0 to 10 centimetres, and the cervix will be thinning out. And the baby would be in a good position coming down through the birth canal. Your doctor or your midwife would have a conversation with you about whether there are any issues, assessing the baby's heartbeat and status, and also whether or not the waters, which may or may not have broken, may benefit from being broken, and this will be discussed with you. As your labour starts to become more intense and the contractions might come every 3 minutes, lasting up to a minute at a time, we would expect that you would be getting increasing dilation, and on an average good quality labour you would be expecting about 1 centimetres progress per hour. For some women it will be quicker, particularly for second and third time mums, and for some women it may be a bit slower. When you get to the active part of labour where you're feeling a feeling of pressure or wanting to bear down, you're fully dilated, that would be the time when you would be pushing. Pushing for some women can be quite easy and for others can be hard. And what's really important is to get your technique right, and this would require good input from both your midwife or your obstetrician. Hopefully the pushing will last no longer than a half an hour to an hour, but again it can be variable based on the baby's size and position, the effectiveness of the pushing, whether or not you have an epidural in or not. Very occasionally there'll be cues that I can pick up on that will determine whether or not I might need to help you in the form of using a vacuum or a forceps to help to deliver the baby if you're having some trouble with completing the delivery yourself. Once the baby is delivered, and we would usually hopefully deliver the baby straight up onto your chest for that immediate bonding, we usually offer delayed cord clamping to allow the baby to establish its blood pressure, also increase its tone and its breathing. We'll then apply clamps and often offer your partner to cut the cord. When it's appropriate, you would then have the placenta delivered, and we usually give an injection with the delivery of the baby to help to facilitate the delivery of the placenta and to reduce any bleeding afterwards. Essentially, if you are well prepared for labour, you can have a much better chance of having a much better birth outcome. It's very important to remember, when you have an assisted birth in any capacity, it is not the obstetrician or the midwives that are generating that birth, it is your baby in your body. Our job, my job, is to essentially assess for the cues and the signs and work out if and when you need assistance. It's important for me to be communicative so you understand what's going on and to know that I'll never just do something just for the sake of it. It's always in the best interests of you and your baby.